Laura, if you can help Nele get sorted on audio, that would be great. And we'll go ahead and get started. So hello, everybody, and thank you very much for joining the presentation today and the webinar today. Just 1 second and we'll. All right, thanks everyone. So my name is Matt Kavanaugh. I am the director of the Global Health Policy and Politics Initiative here at the O'Neill Institute at Georgetown University. We're joined today by the Treatment Action Campaign, ITPC, Health Gap, colleagues from the Richitse Project, AMFAR, and other colleagues at O'Neill. We're really very glad to open this webinar and online workshop on community-led monitoring of health services. And so without kind of much ado, I'll turn it over to start off to Maureen Milanga, who will take us through the first set of slides. So Maureen from Health Gap, over to you.
Hi, everyone. It's a pleasure to be here. It's a pleasure to see the amount of participants we have. It's really great. Thanks everybody for joining. Matthew, we just move on to the next slide. Next, great. So mainly we wanted to cover why it is important, why community-led monitoring is an important tool for us as civil society and as communities who are being requested to do this, and also who have really cared about how service delivery is provided in our countries. One of the main reasons why we need community-led monitoring is to ensure that accountability for all actors, including governments and aid agencies. A lot of the times, decision makers who make the decisions about service delivery and who or where or how people are going to get those services are usually not in direct contact with the people who normally get to receive those services. Often when people live with HIV or communities want to shape how service delivery is given, it's usually a big battle. And community-led monitoring gives us an opportunity to be able to build that system and contribute to national data systems and include communities in how we think about quality service delivery. Next slide. We also think about community-led monitoring in order to be able to highlight gaps in quality service delivery. Whenever when people are going to service delivery points, the main challenge that we are still facing, that we faced for years, is long wait times. We have faced stockouts, we have faced bad infrastructure, unprofessional health workers, discriminatory services, especially among key populations. And even the service delivery currently, you go to one facility, they give you very good services, and you go to another facility and they give you very bad services. Community-led monitoring allows us to be able to highlight those types of challenges and gaps in quality of service delivery. Right now, when we're talking about PEPFAR and Global Fund, and in terms of health service delivery, the main issue that we are facing is we have a lot of people who are going to the facility who are lost to follow-up. We have our retention at facility level is very poor. And even when we were talking about, for those people who participated in the PEPFAR process, the main issue this year was how do we keep people in the facility and ensure that they, once we've introduced them to the facility, how do we make sure that they stay there? So community-led monitoring allows us to be able to work with governments to be able to highlight those types of issues. If you go to your facility and you find out that there's a stock out, through community-led monitoring, you are able to go back to your Ministry of Health and say, I went to facility X in X district and found that there is no medicines. That's the reason why people are not coming. If you go and find long wait times, you can go back and say, the reason why people are no longer coming to your facility is because they waited for 8 hours to be seen by a doctor. This gives us an opportunity to highlight those quality issues that would not otherwise show up in the data systems, in the data that is collected by governments. Mostly governments tend to collect data about how many people have received healthcare services, how many people have, what gap is there in terms of HIV service delivery, but doesn't really ask why the numbers are low and how we can be able to improve those types of things. And community-led monitoring helps us do that. Just to note that when we do community-led monitoring, it is also just not monitoring for HIV alone. HIV service delivery is not done in a silo. When we think about community-led monitoring, and the reason why we need community-led monitoring is because we are responding to the entire health system. If you go to a facility and there's not enough healthcare workers, that affects not only HIV service delivery, but it affects the entirety of the health system. When you go and you find that there's stockouts, as much as there's stockouts of HIV drugs, there's probably stockouts in a lot of other drugs in that facility. So our community-led monitoring does not only cover, does not need to only cover HIV, but look at the entirety of the healthcare system. We also, the need for community-led monitoring is also to gather evidence for advocacy. When we think about community-led monitoring, we need to think about it as a systematic and routine way in which we collect data, the systematic and routine way in which communities collect data, because communities are at the center, go back please, community are at the center of service delivery and they are the users of that service. So community monitoring provides us with evidence to be able to go back and advocate for all the things, all the gaps that we find at service delivery points. It also allows us to be able to go to either collect information routinely or dependent on need. If we find there's a moment where we can see there's an issue at in a certain district where we work, we can go and collect that evidence and come back and advocate for that. So yes, data is a major, using community-led monitoring as an advocacy tool is really important. And the last slide is mainly right now, funders such as PEPFAR and the Global Fund and the French, the 5 Initiative are really interested in community-led monitoring. And as we've seen in many countries this year, in all the PEPFAR countries, community-led monitoring will be supported. And the Global Fund is also thinking about community-led monitoring in its grants that are being written right now. Over to you, Matthew.
Thanks, Maureen. Thanks very much. So as we think about community-led monitoring that's increasingly getting the attention of donors and of others, we want to think broadly about kind of being sure that we're very clear on what it is that we're talking about related to community-led monitoring. So as Maureen was speaking about, the core here is that community-led monitoring is an intervention aimed at trying to increase the accountability, to increase the quality of HIV services, but also of broader services writ large. And so here is one definition for community-led monitoring. And we wanted to just start this section by really emphasizing the idea that community-led monitoring is a specific thing, right? It's not everything to everyone, but it is a very specific intervention. It trains, supports, equips, and pays members of directly affected communities to themselves carry out routine, ongoing monitoring of the quality and accessibility of HIV treatment and prevention services. The kind of monitoring, what we're talking about here is the idea of collecting data through a wide variety of measures, right, or methods. That includes, right, observations at the facility level. It includes a wide variety of data collection opportunities. But the key point is that it reveals insights about what community understands the problems to be and generates solutions to the problems at the facility, community, subnational, national, and even international levels. And that is linked to a cycle of accountability. So 4 elements in terms of how the cycle goes. The first is data collection. And we're going to hear from colleagues with the Richidze project, from Treatment Action Campaign, from ITPC and others about how that data collection happens. But the idea is that it's a combination of direct observation, plus surveying, plus interviewing, plus conducting focus groups and door-to-door surveys. There's a wide variety of ways that communities have for gathering information. That information then has to be translated into actionable insights. So the idea of just collecting information doesn't go very far at all if there's not the capacity built in to make sure that we turn that information into something that can be done about it, identifying the problems and moving forward. That from there, the next step in the cycle is dissemination. That again, gathering information and putting it on a website matters very little. And so a key part of community-led monitoring is disseminating that information, sharing it with facility managers, government officials from the local and national level, the management of NGOs that are involved in service delivery, international funding agencies like PEPFAR and Global Fund, and civil society networks. And then, upon the dissemination, then moving forward, not just with accepting that we've identified what the problems are, accepting that services are not the quality we want them to be, but instead advocacy as an integral part of community-led monitoring, going beyond just collecting data to pushing decision makers to address the problems that have been identified, and then monitoring the commitments that decision makers have made. Creating the accountability for decision makers to the community who use those services. We wanted to emphasize too that community-led monitoring is just one key part of a community system, right? And so the idea is that it provides decision makers information, it provides communities information, it provides insights that only communities have, and then it holds decision makers accountable for actually acting on those insights. But it's just one part, and it complements community-led service provision, one-off rapid surveys, peer support and community outreach efforts, research efforts to gather data for scientific papers. All of those are examples of what community-led monitoring is not, but complements. And so we wanted to just be very clear on that piece because there's been some confusion. 3 quick points. Necessary for community-led monitoring to be effective is that it's owned and led by communities. That is the most fundamental idea here, is that it is not a research endeavor by a university, despite I'm sitting at a university, that's not the goal. The goal is that it's owned and led by communities. And that means they're designing it, they're setting up what kinds of information they want to gather that matters for them, and they're owning the whole system. They're not just inputting into somebody else's system. That second, organized communities are necessary. This is not a one-off, you hire some people from community to do a project. Instead, this is about organized, the most effective community-led efforts are where there are groups or coalitions of groups that are well organized and have the capacity to move this forward and supported to do so. The advocacy component is critical to community-led monitoring. Information alone often leads to problems being diagnosed, but then left unresolved. And then finally, making sure that there is enough resources to actually do the kinds of things that are necessary. Having a few surveys here and there will change very little. A community-led monitoring effort is sustained over time. It's collecting valid information and validating it. And it's analyzing the information that's gathered, which is not automatic. That takes time, skill, and there has to be somebody in charge of doing that. So a wide variety of materials are available. There's this white paper that's online, guides from Richidze and from ITPC, and data collection tools are all online, and we'll share those with the participants. But I wanted to open up for a moment to Solange Baptiste from ITPC to see if you had anything to add, and just in terms of clarifying what is and is not community-led monitoring.
Hi, Matt. Don't really have that much to add. I think you've covered all the bases, and I would like to save our space and time if we can for discussion. So if I think of something, I'll jump in later on, but thank you.
Perfect. All right, we are now over to Anele Yawa. Anele, are you able to hear us?
Can you hear me?
We can hear you, yes. We can't see you, but we can hear you.
That's unfortunate, but when technology is technological, yeah, for others becomes disadvantaged. Hi, colleagues. Thanks, Matt, for affording me this opportunity. I think, colleagues, most of the things that I was to cover, Matt touched based on them. But in South Africa, we are 5 organizations of people living with HIV. That is TAC, NAPWA, Positive Women's Network, Positive Action Campaign, and SANAREL. And all of us, we sit within the National AIDS Council of the country, representing people living with HIV within the sector. And all these organizations are membership-based organizations. Like, for instance, TAC is working in 7 provinces of the 9 provinces of South Africa, and we are operating in more than 250 branches, where each of our branches has adopted 1 or more healthcare facilities, and other organizations likewise. So almost all these 5 organizations are working in the 27 districts that are funded by PEPFAR in South Africa. Then it became our responsibility as these organizations to ensure that we monitor the quality of HIV and TB services in all the facilities or districts where PEPFAR is supporting them. So through that process, we came together as a consortium. We came up with a concept of a Richitse, which seeks to go to each and every facility to monitor what PEPFAR has promised to deliver on the ground based on what is contained on the country operational plan. So what we did last year between August and October, it was a design phase where we visited about 36 facilities in the high burden provinces that are supported by PEPFAR, which is KZN and Gauteng, where we were testing what we want to do, meaning that we had developed tools like your patient survey tool, your facility manager survey tool, with a list of questions that are meant for facility manager or a patient or a person living with HIV and AIDS that are related to what PEPFAR is doing. And in this process, we have been working with healthcare, AMFA and Georgetown University, who have assisted us in terms of developing these tools in order for these tools to be in line with what PEPFAR is doing in our country. So during this design phase, we interacted with some colleagues from CDC, USID, in terms of them having a look into the tools that we were developing, which they approved them. Then in October, we said we are going to train people now, because it was the second phase of our project of going down to make sure that we are covering about 400 facilities in all these districts that are funded by PEPFAR. So we trained about 73 people in October, and these people are working in the 27 districts. And these people, the way they were trained, we have a project team which is constituted by the project coordinator and senior project officers. The other one of them is dealing with the data, and the 2 of them are dealing with the implementation of the work on the ground, and the finance coordinator. Each province is having district organizers whose main focus is around the PEPFAR funded districts. These district organizers are working with community monitors. Community monitors are the ones who are monitoring facilities and also doing education and community outreach in those communities where PEPFAR facilities are. And then in this process, since we have been working with AMFA, Georgetown, and HealthGap, we have developed a monitoring system, which is an automated system, which is called ComCare, where all the people who are working on the ground have tablets, and they are just uploading the information in each of the survey tools on the tablet, and then it goes to a central point where the information which is collected on the ground is analyzed, and on daily basis people are getting a dashboard with the feedback of what is happening on the ground. And it is through this process where we are able to pick up what are the challenges at facility level, and through that process we are able to engage with duty bearers, meaning that if the problem happens at facility level. We immediately, when we pick up the problem, let's say, for instance, there is an issue of staff attitude, health workers who are disclosing the status of people living with HIV without their consent. What do? We pick up that issue on the ground. We engage with facility manager in order for us to be able to come up with a better way of how healthcare workers can address some issues of sensitivity. So also through this process, the data that we are collecting through the Comcare system on a monthly basis, we are going to see it as, it's a pity in South Africa we've got a lockdown, because on the end of March, we were supposed to be meeting with the Department of Health, with CDC, USID, PEPFAR, WHO, and UNAIDS, with other stakeholders, where we will be presenting our findings on the ground in order for the department to be able to address the problems that we're picking up on the ground. Let me pause the colleague Spence.
Thanks, Anele. Thanks very much for that overview. And we'll come back to a few questions that I already see are coming in on the chat, which is fantastic. We'll go through a few more presentations. Feel free, colleagues who are on presenting, to take a look and see some of those. We'll share those. But as we go through, everyone listening, please do join us in taking a look at or by putting in questions into the chat box, and we'll respond to those at the end. So from here, we're going to go over to Mohamed Jallo from ITPC, who is now unmuted. And so over to you, Wame, and we'll bring you to your slides.
Thank you. Good morning, good afternoon, everyone, and welcome to the Community-Led Monitoring webinar. The presentation, or the focus of the presentation I'm going to make, is around how we collect data. This is really critical component of the community-led monitoring approaches, and my colleagues that are on the panel can also share some experiences of how they've actually used or the different data collection methodology that they have to collect data in order to inform the advocacy. Next slide, please. So just a quick snapshot. This is ITPC's Community Treatment Observatory. This is one approach that we've used to actually do our community-led monitoring. It really looks at collecting data along the cascade, in this case HIV, but this is a model that can be applied to any disease area, tuberculosis, hepatitis C, etc. The point of it is to identify what are the critical gaps in the health systems, and to be able to collect data to point to the issues that we're seeing on the ground, the gaps, and be able then to use it to inform evidence advocacy. And a lot of it stems from, or the beginning of it is really communities going into healthcare facilities. If you look at the diagram on the right-hand side, collecting information, aggregating that information, and using it to inform either national advocacy, or if there are a series of community treatment observatories across multiple countries, it can inform regional and also global advocacy as well. Next slide. So in order for us to collect data, there are two things that we need to bear in mind that are quite critical. Number one, if you look at the diagram on the left-hand side, is the team that's in place. It's important to have a set of well-skilled and well-equipped data collectors. The quantity of data collectors depends on the size of the data collection methods and process. And those data collectors, in the case of the CTO, are specifically assigned to the healthcare facility. The data collectors are members of the community, members of organizations, non-governmental organizations, community-based organizations that have a vested interest in trying to ensure that the quality improvements are seen within the health system, and advocacy is actually facilitated. Also linked to data collectors are data supervisors, and essentially it's a more senior person out of the team that is able to monitor the quality of the data that's collected. There's a process to verify and check for the validity of the data before it's entered into a database. And this data supervisor is really critical in that. The information, the other important part of the team is the focal point person, who's usually an M&E, or monitoring evaluation officer or manager, that sits at the national level within an organization, and they aggregate, or they look at all the data that's aggregated nationally. This is assuming that we have quite a number of data collection sites across either health districts or health provinces, across several health facilities in different areas. What is also really critical is support with analysis. And what we've done in the case of the CTO is that we've attached the institution or the organization to an academic institution or an individual who can then support data analysis or verify whether the information that's been collected is accurate. And in some instances also supports the data analysis as well. So the process for our data collection starts with the actual collection on the side. If you look at the diagram on the right-hand side, collecting the data, making sure that the data is validated and verified, entering the data into a database, which is important because the storage of the data, the management of the data is equally quite essential part of the data collection process. And then the analysis that it forms now, what are the key advocacy issues that need to be addressed as we facilitate the work going forward. Next slide. We have two types of data collection processes. We have something, what we call structured data. And the structured data has two categories. There's the quantitative data set that we use, and this is paper-based, or it can also be electronic. The diagrams that you see on the right-hand side are just examples of how we can use, we can approach data collection. So we can either do it electronically using a tablet, or we can do it paper-based, where somebody actually brings to the health facility forms that are completed with the healthcare provider. The quantitative information, depending on your intervals that you think is critical for data collection, can be collected quite routinely. So in our case for the CTO, we were collecting information from the health facility monthly, and this information then was aggregated quarterly and used to analyze and what were the trends that we saw during that quarter. We can also look at qualitative data methods, when this is typically just information or data that's collected from focus group discussions or key informant interviews with actual health facility workers and or recipients of care, the community who actually receives the service. And the beauty of having both sets of data is that you're able to compare, you're able to see the number of people that have actually entered into the health facility that month and access services, and what were the issues, whether stockouts, the attitudes of healthcare providers during the access, the number of viral load tests that were taken. But you're also able to see the implication of what those stockouts meant on individuals accessing the services. What were the reasons for not being able to access services? Was it because the drugs were not available at the time, or there were other delays or health systems issues spotted along the way? So that's the structured data. Next slide. The data that we collect, we analyze it in what we call the 5 A's framework. This is not new to many of you. This is really looking at issues around what is the availability of medicine and commodities within the health facility, what were some of the accessibility issues that were identified during trying to access services. So whether it took the health facilities were a long way away from where people live, or the hours of operation were not necessarily conducive to recipients of care. The acceptability of the service. So this is where we actually want to measure the quality of care in accessing those services. The affordability, and this is where we hear a lot of issues around out-of-pocket expenditure or user fees that sometimes act as barriers to accessing services. And lastly, but not least, is the appropriateness of the service. And this is where we get to see a lot of issues around key populations and some of the stigma and discrimination issues as a result of accessing services. Next slide. Data doesn't always have to be collected in a structured form. So we also have an opportunity to look at unstructured data collection methods. And this is really a process where you're not, is routine, you're getting a continuum of community perspective. So it's not a snapshot of in this particular day, this is what occurred, but over time, we're able to get informal anecdotes from the community members via WhatsApp groups, vlogs, social media engagement. And this is where you get a lot of alerts to say, I went into the health facility, I was treated this way, or I went into the health facility and I was not able to get my results, etc. And these are equally important to augment some of the data that we see quantitatively in the structured data collection process. Next slide. A key and critical component of our data collection is data quality and analysis as well. We hear a lot of times that community data is wrong, it's invalid, it has a lot of errors. And this is where the data quality audits really matter and the data supervisors really matter. So as much as we collect the information, we also want to ensure that we have data quality audits that are part and parcel of the data collection process to be able to spot any errors, verify the information, and also circle back to the health facilities, because sometimes what we see is that the data that we collect, even though there's an error, it doesn't necessarily emanate from the data collection process, but the data itself that was at the health facility may have been inaccurate. So it's always good to have a process where we're able to verify the data that we have, and having an academic institution or an expert supports this type of activity. Once the information is analyzed and our reports are derived, the community consultative groups or communities that you organize to look at the reports can help identify or prioritize some of the advocacy issues and also facilitate some of that advocacy. And we'll see later on in the other panelists how those advocacy gains are made. Next slide. So just quickly, I'm not going to go through the slide, but the opportunity around data collection, community-led data collection methods, is that we're able then to identify what the issues are. And within identification of the issues, we're able to then highlight and facilitate what our advocacy is. And I'm not going to go through this results, it's on our website, but it's to just give you a snapshot of the opportunity for what the information is that you can collect, and the advocacy as a result of that. In Sierra Leone, for example, they were able to facilitate a DSD policy because they saw that access to key population programs was missing. Thank you.
Thank you so much, Wame. Really appreciate that insight, and we will, as discussed, share. We'll share all of the information that is contained in all of these slides. Plus, we'll point you to all of the toolkits and various things that are online. Please go ahead and continue to ask questions in the chat. We're trying to answer some of them as we go, and then we'll bring several of them up for discussion at the end. Brian Hunterman of MFAR, over to you for 5 minutes.
Hi, everyone. Thanks, Matt. Thanks, everyone. Next slide. I'm just going to talk a little bit about building data systems and how some of that can be done and how you should be thinking about it when developing sort of the concept notes and proposals being put together. Just first, because we know a number of the pressures that have been applied in the PEPFAR program in particular, there's been a lot of pressure to get organizations to develop data dashboards as part of their proposals. And we just want to put out a word of caution that, the data and the data dashboards on their own don't fix things. So keep the purpose of community-led monitoring in mind. It really is about getting to all of those things that Matt and Wame and Maureen already introduced of how do you get actionable data. And so these big data dashboard projects, go back, Matt, these big data dashboard projects can take a lot of time and they can take a lot of money when they get put together. And we think the focus should really be on getting data analyzed, getting it processed so that it can be turned into something actionable very quickly. And focus on sort of simpler, flexible tools. The big complex data systems and data dashboards that people sometimes build and invest in end up becoming a trap because they taken so much investment that people are forced to use them, but they may not be answering the questions that people really want to get to. So next slide. So electronic versus paper-based data collection, just in terms of this, it's already been introduced a little bit, but the electronic data collection systems using tablets or using cell phones or whatever are best suited for large-scale projects or longer-term community-led monitoring projects. Paper-based can be done alongside electronic. You can have forms that are both paper and electronic. That's done in the Rachite project. The electronic is just, it's quicker to implement, it's more reliable, everybody's getting the same thing, provides safer data storage, and it also has a lot of advantages around being able to aggregate the data very quickly with some of the automatic tools that are built into those. Paper-based is obviously lower cost, though it does have a cost in terms of printing, and really the design element of paper is really important as well. It's just then the processing time of getting those data from the paper-based into a centralized data repository, into a database, is a lot more prone to errors and takes a lot more time and effort on that side. But it is less training in general required. Next slide. I'm not going to go over this, just flagging for, because everybody will get the slides, there's a number of different tools that are available for electronic data collection. Each have their own pros and cons and functionality and price in terms of them, but they are something that you should be thinking about. Next slide. So phases of data, and I just really want to talk through this because it's really important that when you're developing plans around community-led monitoring, you're thinking through all three of these phases sort of differently and separately and planning for each one differently and separately. So data collection is really the piece that people have already talked about around community monitors going out to facilities, collecting those data, doing surveys, doing observations, doing whatever. One of the important bits about that is really making sure that you understand how you're going to want to analyze the data as you're developing the tools. Because oftentimes we get questions and we design questions, and then when it comes to the later part of analyzing the data, it becomes very difficult because the question was phrased a little wrong. So you should very much be taking into consideration how we're going to analyze the data as we're doing the data, as we're designing the data tools themselves. It's a really important piece. Next, you're going to have a phase 2 of data collection. And phase 2 is really getting those data from either the electronic system or from the paper-based systems and centralizing it and cleaning it, as Wame already talked about. You have to, this is part of the process. You cannot avoid this process. And so you really need to think through what that process is going to be. And then the data can't live in electronic data storage. It can't live where it was stored. So ComCare, all of those, they're good for storing the raw data. They're not good for storing the processed data. And so you have to have a separate data storage plan for those. And then phase 3 is sort of the visualization and data analysis. Again, don't get too fancy and don't overpromise on what you're going to have for a dashboard. And think through what the purpose of your dashboards really want to be, because there's different target audiences. Things like program managers to be able to see which facilities have been monitored, which facilities haven't been monitored, so that they can follow up with the community monitors to say, hey, we haven't gotten the data yet from this facility. Or the data analysis side to identify where problems are, and then start working towards the advocacy effort at those facilities. Next slide. And then just last things to consider, approach to qualitative data, thinking through how much qualitative data you want to get. Qualitative data, as ITPC already talked about, is really important, but it also takes a lot more effort in terms of the analysis to do. And so more isn't necessarily better. It's a lot of filling in gaps of what happens in quantitative data, but it's important to have a plan around that. And then photos are obviously really powerful, and a lot of the tools aren't necessarily designed to collect photos. So developing a plan around how you're going to get photos into the system, how you're going to tag those photos, how you're going to store those photos so that they can be used as part of the report generation and the feedback to facilities. These are just some of the examples from the Rachite project. And then we'll be happy to take questions later.
Thank you very much, Brian. Much appreciated. And so again, questions, please go ahead and stick them in the chat. We'll continue to answer them, and we'll move ahead as we go. So final presentation, going to turn to Lottie Rudder from HealthGap, and it is over to you.
Thanks, Matt. Okay, so we've got to the stage where we've collected our data, we've analyzed our data. So what do we do next? We've found out what all the problems are. We found that there's stockouts in the system. We found that healthcare worker shortages are there. We found that the facilities are dirty. People are being shouted at. So what do we actually do next? Next slide. So this is just showing with the Richardson model, the kind of process of the flow of the model. So after the data collection, after the compilation of the data and analysis, we get onto the section of using that information to actually generate some solution. And following the solution generation, we develop reports and other material in order to engage duty bearers. And from there, if no change occurs, then it's time to develop an activist campaign to push things forward. Next slide. So in terms of the problems to solutions, we take different forms of thinking about this in the Richardson model. There's solutions that we can think about as team members who are monitoring the facilities of what solutions can fix some of the challenges that we're seeing. We can think about it in terms of what are the short, the medium and the long-term solutions that can be found, and what are the most important things to fix at that stage. Then there's a kind of area of solution generation that you might not find the solution as a member of the community monitoring team. Maybe you need to engage with community to find out what those solutions could be. So there's the organization of community dialogues and other means of engaging the community on what the challenges have been, getting their input, and trying to come up with community-generated, community-owned solutions and taking those back to the facility. And then there's solutions which are just not going to be fixed at the clinic. A clinic is not going to be able to resolve a challenge of not enough healthcare workers at the facility. That's not something that's in their control. So then there's going to be solutions which are at higher levels to be fixed at a higher level. Next slide. So the next phase, after we've worked out, so we have our problems, we have our solutions, and now we need to put that all together in order to engage with the duty bearers in a logical way, in a smart and impactful way. And so we develop state of health reports at various levels, depending on who we're trying to engage, who we're trying to feed back to. So at a clinic level, we might generate a state of the clinic report, which outlines what the problems are, the analysis from the data, the solutions that are being suggested, in order to take to a meeting with the facility manager, in order to feedback what we found and try and get them to commit to implementing some solutions that we can then hold them to account to implement. Or maybe that's at a district level, with engaging with district health teams to try and fix at a district level. Same thing at a provincial level or at a national or even international level. So some of the examples on the slide is just the release of using community monitoring data to develop provincial state of health reports, or the People's COP, which is a means of influencing what PEPFAR spends its money on in South Africa. So it's just some of the kind of means of engaging. And in terms of the cycle, the monitors will monitor on a quarterly basis, and after each monitoring, they immediately develop these reports and feedback straight away to the facility in order to try and get them to make the changes. So the next time that we're monitoring, if the changes haven't been implemented, we know we need to escalate and try to resolve them quicker. Next slide. So one of the methods we've been using for engaging duty bearers and kind of escalating our tactics a bit has been the use of community meetings. So basically bringing together people that you found through the monitoring system, whose challenges are the challenges of the problems that you found. Their personal stories replicate the challenges that you found on a kind of broader data level. And so by organizing a kind of accountability meeting where you have in the room community members affected, you have in the room decision makers or duty bearers who have the means to change those challenges. And by presenting the data and then hearing people's stories straight afterwards that like directly relate to those data challenges is a very useful advocacy tactic that kind of raises people's voices, and it puts like extreme pressure on the targets to address those challenges. For instance, it's very difficult it's easy for someone to say, well, we don't need access to condoms for young people. But then if a young person who's pregnant is talking about why they wanted access to a condom, it's much harder for that decision maker to just dismiss that as something that is not needed. So through the Richitse model, we use different data collection methods in the community to try and find people who have stories, who want to stand up and say what the challenge is, in order to bring them into these kind of meetings to put pressure on the decision makers. Next slide. So when is it then time for like a bigger campaign? If we've analyzed it, if we've gathered the community data, we've analyzed it, we've generated solutions, we've engaged with the duty bearers, and then nothing has happened, then it's time for us to like escalate that into a campaign. Next slide. So there's two ways in the Richitse model that we escalate. We either escalate upwards, which is what this slide is showing. Perhaps we've found the challenge at a community level, at a clinic level. We've engaged the facility manager, we've engaged the clinic committee, we can see there's no change being made. Maybe we escalate that then to a district level. Maybe we found a district challenge, which is affecting the entire district, and the district team doesn't want to listen or change that challenge. We might escalate that then to the province or to national, and so on and so on. So there's this kind of stream of escalation upwards of challenges that aren't getting resolved. And then next slide, there's a second level of escalation, which is like the type of tactics we use to escalate. So maybe at the beginning, we're starting with report writing, letters, having meetings, engaging with different structures who perhaps have the power to make a change at a clinic level or at a district level. And then nothing happens. So then maybe we like take our tactics to the next level. Maybe we start doing some media work. Maybe we start getting coalitions of people signed on to things. And maybe we start exposing the issue on social media, and nothing happens. Maybe then we have to take it to the next level of you know, kind of taking it to marches or sit-ins or other tactics to really expose the challenge and push for a change. So there's different levels of escalation, whether it's upwards or in terms of tactics, in order to try and ensure that the problems that we found are actually being resolved, and they're not, you know, just going on forever. Next slide. And then there's some things where you need a rapid response on the day. You know, we're not going to get a rapid response on the day of not being enough healthcare workers, but if there's a stock out of the first line ARV, then we need to get that resolved on that day. If there's a safety challenge, then we need to get that resolved on the same day. If people's HIV status is being exposed, then we need to try and get those things resolved. Next slide, please. So there's different things that we ask the monitors to ask when they're there. So can the facility manager fix that situation? If it's a no, then immediately we need to take that information to the next level in order to work out who actually has the power to resolve that situation. If the facility manager has the power to fix it, are they aware of that situation? And no, if they're not aware of it, then let's take it to their attention and see if they are able to then fix it. If yes, they are aware, but either they're unable to fix it or they are hesitant or not fixing it, again, it may need to be escalated in order to get the resolution that is needed. Within the Richitse model, we have a system of you know, simple things of like WhatsApp groups with the National Department of Health, with the PEPFAR technical team, in order for, if on one day we find a PEPFAR implementing partner being abusive and shouting at people living with HIV, then we'll immediately tell the technical team so that they can go back down to the implementing partners. Or if it's a National Department of Health issue, we'll immediately escalate it to that issue so that they can try and resolve it as soon as possible. So they're totally in the loop. And we have regular meetings with those teams and also feed into their own structures of trying to assess what the challenges are at a facility level. And I think that's the end of my slides. Oh no, one more slide, sorry. So this is just one example of a rapid resolution of a case. So at Regis Park Clinic, there was a stock out that had been ongoing for a very long time of second line ARVs. When we attended the clinic, we found that that stock out was in place. We found people who were not getting the medicines they needed. And so a call was made immediately to the PEPFAR coordinators, the PEPFAR site, in order to find out what the challenge was. Because the people at the clinic had said there was no transport, and yet we found PEPFAR implementing partner cars sitting outside of the facility. So a call to the coordinator led to medicines being found and being brought to that clinic and the issue being resolved by the next day. So sometimes a rapid resolution is really important to engage, because we're not collecting, we're not researching in order to collect for a research project. We're finding this community data in order to shift things as quick as possible to support the community. Thanks, Matt.
Great, thank you, Lottie. All right, so with that, we're gonna go ahead and turn to a set of questions. Thank you all for the fantastic questions. Please go ahead and keep them coming in the chat box. We'll answer some of them via chat, and then we'll also try to answer some of them live. We'll go for another 10 minutes and see where we go to. And so please do go ahead and type them into the chat box is ideal. Let me start with this one, which I'm gonna kick over to Solange to start with, which is, how are things being adapted for COVID and what's happening right now? We've described the high level strategy, but how are things being adapted? What's working, what's not? And then how are you thinking about kind of medium term efforts? Go ahead.
Hi, Matt. Thanks for that question. And yeah, really important, right? Because we're living in the real world, and most of what was described was pre-COVID, sort of, this is how this would work. And I think we've all had to think on our feet and become more nimble and figure out how to adapt the models that we've all shared here. I think the most important thing I would want to emphasize is that we don't go hiring a whole bunch of new people in order to do this work. I think within the COVID situation, it is a public health emergency. We need to really rely on people who are already out in the field, who are doing work, going out, and they have to have proper protection, the personal protective equipment, and that we don't just hire people to do a project, that these are people who are already in the system. We use as much as possible the existing architecture and community group organizing structures that are already in place, and those are sort of the backbone by which any community-led monitoring that's being done now should be building off of. It's important to think about local feedback and systematic collection. So is sort of an immediate acute need, potentially looking at what's happening within the local ARV clinics at the local level, and how their services are being impacted, and what you want to report up for sort of very local. And then you want to see what's happening over the course of time for the bigger picture in terms of systematic data collection and change, and a bigger subnational level advocacy, potentially national level advocacy. We had a question about the stop stockouts, and sort of, again, any data can be built into systems that already exist. I think we need to make sure that we're smart and savvy, especially if you're trying to look for funding and write a proposal, whether it is PEPFAR or Global Fund, or if it's any other potential donor. You want to be able to build off of what's already there. And you want to be able to support the data collectors. So it will be a person who was already either addressing maybe the lead of a community adherence group who was going to collect medicines. You can see, okay, as you go in your frequency to the particular clinic, can you also collect these 6 indicators, answer these 6 questions, like, is there personal protective equipment? Is social distancing happening? Is there a stock out at the clinic? So you want to be able to get that information. But to the extent as much possible, distance support. So one of the things we found is obviously psychosocial support, which was depends on who you ask, one of the biggest components of these support groups and teen clubs and adherence groups is not just to get your medicine, but to sit down and give the psychosocial support. And that sort of meeting is now not happening. So you're trying to figure out also how the distance support can work as part of what you're doing. And then also just thinking about what to budget for. Budgeting in particular for data. You need to pay people for their time and budget for what it actually costs. So if you need to get a phone, if you need to put a tablet in someone's hand, if you need to be able to pay for the data top up, if you are paying for people to do the same person who is the adherence sort of delivery person, if you need to pay for their petrol because they also then, whatever it is, cost it out and try to put it into the budget. So be smart with COVID. Do not put anyone in any undue risk. So people need to be fully aware. And there were many questions about the education component of it. So not only about HIV, but now HIV and COVID and the prevention of COVID as you continue to do the community-led monitoring.
Thanks, Solange. And so as we move to opening up for a few other questions, as time permits, we'll go a little bit past the hour just to allow that if folks can stay on. We want to make sure that it's clear this is one in a series of conversations. So what's happening right now is that we know PEPFAR and Global Fund are both funding community-led monitoring, and PEPFAR in particular is going to scale it up to all countries where there's major PEPFAR investments. And so that means we know that colleagues are right now writing concepts and trying to get engaged and figuring out what this is. So as folks are doing that, the second and third are going to focus in on 2 pieces, one around data and how you use tools and those kind of things, and another around really writing that proposal, what should be in it, things like budgeting, those conversations. So we'll have, for those that are engaged in community monitoring that want to go deeper, we'll have a series of conversations to come. And so on that front, we'll also share all of the presentations that have been made, and we'll send an email to everybody that registered with a bunch of links that you can gather some information about and connect with the colleagues. Moving then to a set of questions that are on here. There was a question here over to Anele about how government is involved and how you engage with government within the process. And there was also a question about how it connects with Stop Stockouts and those efforts. So I wonder if you might talk a little bit about those 2 questions.
No problem, man. So yes, I can say partly yes, we are involved with government because firstly, we have the MOU with the National Department of Health, which was signed by the Director General. Through that MOU, after the DG left, we were able to have a couple of meetings with the Deputy Director General, Dr. Jochen Pillay, who assisted us in terms of reaching out to other HODs in provinces in terms of introducing the project. That's how we were able to be welcomed in many of the facilities in some of the provinces. And through that process, where we got pushback in some facilities, we were able to agree with the Department of Health to say we need to come up with a list of all those facilities where some of our colleagues were not welcomed or accepted so that they can be able to address that. Also, on the issue of the Stop Stockouts, one needs to remember that Stop Stockout is a consortium which TAC is part of the steering committee of the Stop Stockout project. And all TAC branches in more than 250 facilities that we're monitoring, part of our monitoring is to monitor the availability of medicines, but also through the Richitze project, we've got on these monitoring tools, more especially the one that talks about HIV survey. It focuses on the availability of HIV and TB medicines in each of these facilities. So through that way, we are able to pull out the information of what is available in each facility and what is not available in each facility. But we also had a discussion as the project team to say, in our monitoring tools, we need to include the toll-free number of the Stop Stockout project so that some of these cases can be able to be reported online. There was another last question. So how we work, as I have said, these organizations are membership-based organizations, and the members of all these 5 organizations are part of the 8 councils at local level, district level, and at provincial level. But also, members of these organizations are working with other networks of people living with HIV, like your support groups, your adherence clubs. We normally visit them to engage with them, but also to provide education in terms of people adhering to their treatment. Thank you.
Thanks, Anele. That's really helpful. So there's a series of questions here that I wanna kick over both to Anele and to maybe Solange. The Alan Mamio, I think it is Mamlo. No, sorry, Ali Mamlo asks, most of the programs depend on much on donor funds. How can you assure the sustainability of CLM? There's another set of questions that asked, are the monitors paid? And how have you secured funding to make sure that they're paid? And then there's a set of questions around kind of how to make the case. And so I wonder if you all might speak to, you know, the kind of budget aspects of this and where has the money come from and how are we working to ensure sustainability? Solange, do you want to kick off?
Sure. Those are not easy questions. Look, it's a work in progress. Community-led monitoring is a fancy name that we try to coin now as the world, but community-led monitoring is not new, right? So this was happening where people were doing it in a much more ad hoc way, writing down what medicines were not available. And so now to actually try to get this paid for and legitimized and normalized in the HIV response is what I think the global networks and our partners in the country are working on desperately. And I think we've made some progress with that. We've gotten the attention of Ambassador Burke saying that she wants to see this kind of work everywhere. And so therefore, this is why I think you're seeing it in the COPs and there's sort of space for it. I think if we do not guard that space, it will be overrun by the cost of medicines and everything else. Community-led monitoring will come out, the budget will be stripped down. We have, from ITPC's perspective, gotten funding from the Global Fund in order to do this work in West Africa. I think we have performed very well in the sense that we can show value for money. We have shown that there have been advocacy outcomes and the investment in PLHIV networks themselves to conduct the work via the entire monitoring and advocacy processes has actually borne fruit. And I think those are the things you need to rely on. The evidence, because as Lottie was saying, it makes no sense just gathering data if there's no advocacy and advocacy wins. So you have the work of Richitze, you have the work of ITPC, but also the work of many other partners that may not be named in this particular call, but it's out there. And I think those are the things you need to rely on if you're trying to make a case and sort of fight down someone in the CCM and that says that there's no money for community-led monitoring or in a concept note writing part for the COPs. The sustainability question, very difficult. I'm not quite sure what the answer is, but the more you do well, then the more you can say that, look, this thing actually works. And that goes back to this whole thing about how can you tell that the data is reliable because it's community data. And I say, yes, it's community-led data gathering of what is already out there. So if we're finding an error, it's not our error. We have found an error in your clinic data. we have exposed what your data is showing. So it's, if you see what I'm saying, it's not like the community is generating errors or bad data. And the partnership for us was with an academic institution to kind of verify the data. And what everyone has been saying, being able to walk alongside with the governments as needed to be able to open doors, the MOUs, as Anele was explaining, are all part of it becoming more normalized also for governments as part of M&E systems and health systems going forward.
Thanks, Solange. Lottie, can I come to you on a next question, which is over here. There's a question about how to think about data and how to think about stories, right? And I think one of the questions here asks, often information can be distorted by a single story that somehow becomes the narrative of what's true. I know that Richitse is bringing together in part both the kind of storytelling pieces and sustained data, so we know, is that just a one-off example or not? Can you talk about how that's done and how you're thinking about the two different?
Yeah, so when it comes to the data collection, we have a specific patient survey, and the patient survey leads into an HIV specific survey if someone's willing to talk about that with us and living with HIV. So every time the monitor goes to the facility, they should try to get at least 15 PLHIV stories, which means maybe they get 30 or 40 patients, data, the surveys filled out, which would include like a number of patient surveys in trying to find those PLHIV willing to speak out, obviously to the extent that that's possible. So we don't just generate one person's view of the facility as a patient. We try to generate like a range of people's understanding what's happening at the facility to try and see if it's like, if everyone says there's a bad attitude of nurses at this facility, then we can see like that's a widespread problem. If one person out of 30 says there's a bad staff attitude at the facility, then, and everyone else says it's wonderful, then you can understand maybe that person's just had a particularly bad attitude, which is still important, but it's not going to sway everything. So we start with that, and so we've got a good sense of what the challenges are, and we also use kind of observation surveys ourselves and seeing what the challenges are that we can view at the facility. So we get those sense of things. And then we use different methods like going door to door, or community dialogues or focus groups in order to find more people who use those specific sites and find out what their challenges are. And where their challenges often will just be representative of what we found through our data collection. So we may have found that people wait for 11 hours at the facility and there's a terrible staff attitude. That's what we found through the broad data collection. And then when we go and find stories, we've got particular people whose specific individual stories speak to proving the case of those challenges. So that's where we mold them together in using, here's the data, here's what this amount of people are saying about these problems, and then here's a story to highlight the kind of the personal affront of being impacted like that at the facility. So it's a powerful kind of advocacy tactic to link the two things together, because no one can say, oh, well, it's just anecdotal, because you've got your data to back it up. But then no one can just forget about the people behind the numbers, because you've also got a story to go with it.
Thanks, Lottie. Let me go to Anele with another question, which is twofold. One is kind of following on the conversation around funding. How have you thought about who gets paid and who doesn't? But also, how can you speak a little bit more about how you've brought together different organizations? There's a number of questions in the chat here about how can small local organizations be brought in? How do you deal with a number of different communities that are not all equal and are not all capacitated? How do you think about bringing them together? So over to you, Anele.
Okay, thanks, Matt. So since as the PLHIV sector, we have been part of the engagement processes of PEPFAR and country operational plan. And in South Africa, we had a problem during the implementation of the COP18, where we had a decline in terms of people who were dropping out of treatment, loss on follow-ups and all what have you. So as the HIV sector, we came together and then we came up with a concept of how best can we assist in terms of reaching out to our communities, trace our colleagues who have defaulted on treatment and link them back to care, empower communities to understand their rights so that when they get to facilities and they get discriminated, they know what processes to be followed. When they go to facilities and they don't get their medicines, they know where to report and what processes needs to be followed. Then from there, we engaged with PEPFAR and the agencies to say, as the HIV sector, one, we reminded them about the JIPA principle, and we asked PEPFAR as to say what is it that they are doing that benefits directly organizations of people living with HIV in South Africa. It is through that process where we agreed with PEPFAR that the two agencies, USID and CDC, will allocate resources to the HIV sector. Then we, as the HIV sector, we agreed that the money must not go to these organizations. The money must be sent either to WHO or to UNAIDS. Then we, as these 5 organizations, we then agreed that one organization out of these 5 organizations must host must receive the funding on behalf of all other organizations, but also simply because this project is independent from our organizations. That's why it has its own management. So the duty of TAC is to receive the money on behalf of the project. All what goes to TAC is the money of the administration, and then the project team is the one that is running the day-to-day businesses and management of the project. And then since these organizations are 5 and each of these organizations has a leader, so these 5 leaders are playing an oversight and political, including advocacy role on what needs to be done on the ground. So through that process, we agreed that all staff members of the project who are working on the ground, they will be they will be incentivized in terms of payments and all what have you. So since TAC is the one that is hosting the funds of the project and we are using TAC systems and all what have you, we agreed that according to the different levels of staff, like your CMs, your DO, your senior project officer, so their salary scale will be in line with the existing the different levels of TAC. In terms of the sustainability of the project that we are doing in South Africa is a first of its kind. And if it was not because of the lockdown and the COVID-19, I'm sure by now we could have done a lot of work and we could have made a lot of impact in terms of collecting the data on the ground, doing analysis, engaging with duty bearers in order for us to be able to make a change in the impact on the ground. So I'm trying to say, at the present moment, we engage through the PEPFAR COP20 consultation processes, and from where I'm standing, there is a promise that Richidze is going to be funded again by PEPFAR for the implementation program of COP20, because we were funded for COP18 and COP19, and then now we are looking towards being funded for COP20, but we are still exploring other avenues of people who can fund the project for longer purposes. Thanks.
Thanks, Anele. So, friends, we really appreciate everybody being on here, and we really appreciate all of the fantastic questions. We also appreciate that everybody has limited time on their schedule. And so here's what we're going to do. We've captured all of the questions that you're asking. We will, if we haven't already answered them in the Q&A, we'll go ahead and answer them, and we'll share that in a document around to everyone that registered so that everybody gets an answer to these fantastic questions. There's way more than we could possibly cover. The other thing that we'll do is we're going to have a follow-up webinar. So everyone should virtually raise their hand if they're currently planning on trying to put together a community-led monitoring project, or you have one running that you're trying to get funded in various other ways. So I see a bunch of hands going up. Great. You can also just raise your hand in your piece. I see a whole bunch of them. That's fantastic. What that means is that there's a really interesting opportunity for those folks that are in the middle of thinking about this to get together and exchange some experiences. So we'll do a follow-on webinar for those that are in the middle of writing pieces. Also, if you're in the middle of writing something, please feel free to reach out to us. You've got our emails and we'll share them around. And we can try to help where we can to think through this as you go, but we'll do a follow-up webinar on that. And then we'll do another follow-up quickly on tools and data systems, et cetera, and the questionnaires that have been used and all of these pieces. Let me just end by saying this. We would love to hear 2 sentences from each of the panelists as we close. If you were right now writing a concept note or writing a project trying to get something like this off the ground, what's the one piece of advice you'd make sure that people pay attention to? And we'll follow that up with a bigger webinar on the topic. But everyone gets a chance, if you'd like it, to go ahead and throw in one or 2 sentences. Who would like to start? I can call on you. Lottie Rutter, I call on you first.
I was answering a question in the question box and not listening to you.
I call on Solange first.
What's happening? Okay. Yeah, I don't know if I'm gonna, okay, so I would say you have to be very strategic in picking your indicators. What is it you want to monitor? Because if the design is wrong at the start, you're going to fall apart and they're going to say communities don't know what they're doing. So take your time and design. Don't rush it. Figure out what are the relevant indicators. Don't let PEPFAR or Global Fund tell you must monitor this because they want it to feed into their systems. Yeah, maybe you make an allowance for some of that, but do what is relevant and important to communities. And make sure that you're not hiring McKinsey to do your analysis. It should be like a local academic consultant or in like university that's close to you that is able to support you as you do the data analysis so that you could figure out the right number so that you can say this is more representative and this is actually a trend rather than these anecdotal pushbacks you'll get, particularly because it's community data. Thanks.
Thanks, Solange. All right, one or 2 sentences to everybody else. Thing that you would make sure to do. We appreciate you, Solange. Deep insights, limited time. This is perfect. Over to Brian.
I would echo Solange in terms of getting the data tools right, but I would also about the scale of think about the scale of the project. You don't need to be in every facility. You don't need to go to every place. Part of it is getting an understanding of what types of problems there are, and then putting the pressure back on PEPFAR or Global Fund to resolve them across all facilities.
Perfect. Wame.
Sure. 2 things. Treatment education is critical. So understanding the issues that you're trying to collect, that's the backbone for being able to prioritize indicators. You can't collect everything under the sun, so make sure you're collecting the indicators that matter the most. And then secondly, it is establishing a relationship with the health facilities. I think that's a question that kept on coming up. That's really critical in the data collection because you need to be able to advocate, but also work with the health facilities to routinely get that data.
Thanks, Lottie.
Key thing is to not overpromise and to phase in slowly. It takes ages to get started and set up your system. You're not gonna, within a couple of months, have a data dashboard and have everything running smoothly and have everyone trained and understanding how to use the tools and people to understanding how to use the tablet, and you're gonna get challenges all the way. So rather under promise, start at a low level and build up slowly. As opposed to thinking that in month 2, you'll be doing 100 facilities and it'll be perfect.
Anele, any last word? 1 sentence, 2 sentences, things to consider when writing a concept?
Community-led monitoring must not be about funding, but it must be about building community systems, ensuring that services of people living with HIV are in the forefront, but also involve communities and people living with HIV and AIDS when doing the implementation. And also, let's not reinvent the wheel at community level. Thanks.
And on that note, we'll close this up. We would love to thank you all for joining us, especially those that stayed all the way to the end. There's a number of key takeaways here. One, community-led monitoring is getting a lot of attention right now. There's a lot of opportunity to push it forward. Two, there needs to be sufficient opportunity to make it good. That the push to say, is everything community-led monitoring? I think everybody on the panel would like to say no. Not everything is community-led monitoring, and community-led monitoring cannot be everything for everyone. It is a well-funded effort to sustainably and regularly use community knowledge to improve the services that are being delivered for communities. And if that's what it stays as, and we focus in on that, there's a real opportunity to have that have huge impact. Because when we create accountable systems, we know that they deliver. And we know that aid systems are really bad at having accountability, and many government systems are really bad at accountability. So this is trying to introduce the ability for communities to share their knowledge and hold their leaders accountable. So on that note, we'll close up. Thank you all very much for joining us. We really appreciate it. We will share the slides, we'll share a recording of this presentation, and we'll share a number of links going forward. We look forward to seeing you all, talking to you all soon. Thanks for joining this webinar. Bye, everyone.
Bye.
Bye, thank you.
Bye, thank you.